Thank you very much, Dr. Abarama and the organizers. I must say this meeting's much tamer. My frame of reference is about 25 years ago when I presented a paper on wall stents in the SFA, and I think I got roasted in the process. I'm intimidated by this panel, and I'll try to take just a few minutes to help you understand vascular medicine from my perspective, and that's my disclosure. I have a strong bias towards vascular medicine. I practice in Greenville, South Carolina. Vascular medicine has been around since the 1950s, having originated in the Mayo Clinic from physicians that were interested in taking care of hypertension. They naturally morphed into the field of vascular medicine. Over the years, we have struggled to grow our training programs that wax and wane between 17 and 25 programs. Most are strapped by financial constraints and the unrecognition of vascular medicine as a distinct specialty unto itself. We send out about 22 to 25 fellowship-trained general internal vascular medicine practitioners a year from these programs. A recent competency training statement came out this year. It builds upon what Mark showed you in regards to COCAT's 1, 2, and 3 level training. It's been co-sponsored by medicine, cardiology, and surgery specialties, and it outlines a dedicated curriculum approach to the identification and treatment of arterial, venous, and lymphatic diseases. Yes, there are people out there that want to dedicate their career to seeing swollen limbs. And this is the cognitive aspects behind vascular care, which is where the emphasis is. And it's very complementary, not competitive, to those that focus more on treatment modalities. For your vascular medicine practitioners, most of which center their practice on the medical management of risk factors and the care of complex venous thromboembolic diseases, many of which participate on PERT teams. Many also work in wound care centers, which, as you know, is a complex entity, and it does help when they understand not only antibiotics, hypertension, diabetes management, getting that hemoglobin A1C down to a reasonable level as quickly as possible. And also the vasculopathies, people that are actually interested in vasculitis, fibromuscular dysplasia, and the less common vascular disease, and actually willing to look into a differential diagnosis and comprehensively evaluate the patient. Not that that isn't something that anyone else can do. That's just the training background, and that's what I want to highlight in regards to the relationships and the process that I've gone through. Some do peripheral arterial intervention, but most of our programs, that is not an avenue of access to getting to do this stuff. And some of our programs do train in superficial vein intervention. Most learn to read vascular labs and are also RPVI certified. I'm going to show you 3 pictures of blue toes, if you will. When you say the word blue toe syndrome, oftentimes you're thinking of cholesterol atheroembolization. And certainly the picture on the one side where you got the splotchiness on the lateral portion of the plantar aspect of the foot with ischemic heel fissure, most everyone would say that's classic atheroembolization. But how about the other one on the right? That's Pernio or Chilblain's disease. Always occurs in cold, moist months, most typically in South Carolina in the month of February. You see the bulbous toes, the light bulb type shaped toes that are almost pathognomonic of this entity. The workup of blue toe, oftentimes it leads to a non-invasive study, which you see the flat toe waveforms, and then anyone can order the CT scan to look for and identify the source or location of the atheroma. But how about this one? And the patient was labeled as a blue toe syndrome, was treated as atheroembolization, and underwent a left common femoral patch angioplasty, only to return with thrombosis of his popliteal artery later. And then it was clear that the source or the problem of atheromatous burden was not as great. put into a more of a comprehensive thought process. This patient actually was diagnosed with antiphospholipid antibody syndrome and actually was thromboembolism rather than atheroembolization, which is an important distinguishing feature in regards to how you're going to work up the patient and ultimately treat the patient. At the Cleveland Clinic on Monday mornings, we do journal rounds and, journal review, and we would take the most updated papers and tease them apart. On Tuesdays was the most dreaded, stressful meeting known to man. Dr. Jess Young, I must say he passed away last Friday. My mentor extraordinaire and the pioneer of our field certainly will be missed, but what he used to do to us, he'd put up an arteriogram or a venogram, and he'd send you to the front and then say, explain it to me. He wouldn't give you any background on the patient. So you'd have an image like that, you'd look at it and say, not much atherosclerosis. I see something. Is that an aberrant right hepatic artery that has an aneurysm to it? Is there something funny in the left renal artery? And he'd ask you to tell the story about the patient with no background information. And most of the fellows, they'd either take a beta blocker that morning or they'd be drinking the night before they get put up in front. But what it forced you to do was think on your feet. He actually forced you to think. Well, on Wednesday mornings, there'd be an attending lecture, or they put some patient up in front of you. And also, and try to help you improve your physical examination skills. Everybody know the name of this sign here? Called the Croc sign, in which you blanch the skin, and there's late fill centrally of the blanched skin, typical of acrocyanosis. So how do we think? How do we think about patient care? Well, there's a patient-focused process, there's a problem-focused process, and I think with the depersonalization of medicine, we've kind of morphed into one side more than the other, unfortunately. Both processes start with thinking. Walk in the room, start thinking. In a problem-focused thought process, there's a kind of a directed history and physical examination. Where do you have leg pain when you walk? How far can you go before it comes on? Does it ever come up in your thigh or buttock? How long does it take for it to go away? That's followed by an ultrasound or a CTA. A decision's made as to what to do with it. Do you balloon it, or do you leave it alone? Do you bypass it? Then you treat it, and then you follow up. Did the symptoms go away, and were the ankle breaker indices normalized? If it didn't, you'd go around again. Contrast that to the patient-focused thought process, in which a more thorough history and physical examination is performed. What's their risk factors for atherosclerosis? Could this be a presentation of a non-atherosclerotic disease causing these same symptoms? What's the differential diagnosis? Always force yourself to think of one other thing that can present in the same way. Dr. Young used to say that to you all the time. Followed by a more comprehensive laboratory evaluation. What's the hemoglobin A1C in that patient that presents with the critical limb ischemic foot? Would lowering that lower the infection risk? Certainly would. But anyhow, more of a comprehensive approach to the laboratory evaluation. Then stop and put it all together before you offer a treatment. Followed by a response of the whole patient. And then if there's left undone issues, then go around again. Friday mornings led to a combined collaborative conference between vascular medicine and vascular surgery, and hopefully you recognize Drs. Krajewski and O'Hara and Bevan and Dr. Hertzer. The fellows at that time were Dr. Sullivan, Crowshore, and Dr. Cox. These are my mentors as well. For vascular medicine is not learned away from icons such as these. But in this meeting, it was really helpful. We learned to understand disease in the same way. Even though it was an M&M conference, and you understood the pitfalls and problems with some of our procedures, it put us all on the same playing field in regards to understanding disease. And patients were co-admitted. We worked on them together. So when they're in the operating room and we're rounding on the patient and they have a potassium problem or whatever, we take care of it. If they needed medication changes, we take care of it. And if there's a surgical issue, we'd notify them and they would take care of that. There was this collaboration and there's this cognitive input from the medicine side that was received. There was this conference, but there was this culture that created a mutual respect that's paramount to the ability to move forward. It didn't just impact patient care, it also impacted research efforts. You know, Dr. Hertzer was thinking about looking at cardiac caths in all of our patients that have peripheral arterial disease or carotid artery disease. And he went to Dr. Young and he said, I think we ought to study some of our patients. And Dr. Young said, why don't we study them all? And that's when they started cathing absolutely everybody and led to the landmark studies that came out of the institution because of collaboration. Let's learn to learn together. Fast forward 22 years, I've been down in Greenville, South Carolina. I am a salaried individual in the Department of Surgery, even though I'm not a surgeon. I'm not offensive to my surgery colleagues. I am offensive to them as I maybe express a difference of opinion. But with a background of mutual respect and understanding disease the same, we can agree to disagree on certain things. And it works. It absolutely works. I think I've trained a bunch of vascular surgery fellows over the years, and it's a privilege. It's absolutely a privilege to work with such fine people, and I hope it impacts the quality of care that they actually go out and provide. My objective is to teach them to think well. That's what was given to me because of my mentors. So in conclusion, no doubt, vascular surgery training and vascular surgeons are broad-based and extremely knowledgeable. And I do think vascular medicine physicians bring along a cognitive side and a cognitive perspective to the care of the patient that advances the field. We can work collaboratively for the betterment of patient care. I do think from an economic standpoint, the more patients that we see, stage, and study, the better it'll be. Two foundational principles: we must understand disease the same. We must base respect because we hang out together, and we build upon that through experiences in patient care. I think we're all struck by the depersonalization of medicine. How better are we going to get back to personalized medicine? By working together and learning to learn together. So thank you for the opportunity to speak. Been a privilege.